Son. When writing conversational English for a highly realistic TTS system, it's crucial to replicate the messy, imperfect nature of real human speech. Here are the key conventions to employ. 1. Disfluencies and fillers. Real speakers constantly use filler words to hold the floor while thinking. Use, well, so and right frequently. Example. It's a really complex mechanism. 2. False starts and reduplications. People will often start a sentence, change their mind, or repeat words while gathering their thoughts. Use dashes to indicate breaks. Example. But they found out the whole model was flawed. 3. Active back-channeling and interjections. Listeners don't sit in silence. They actively acknowledge the speaker with short confirmations or reactions. Example. Yeah, oh, wow, wait, really? 4. Overlapping thoughts and collaborative sentences. Speakers frequently finish each other's thoughts or jump in right as the other person is wrapping up. Example, host speaker. So they just decided to, expert speaker, to scrap the whole theory, yeah. 5. No ellipses. Do not use Q-fall for pauses or trailing thoughts. Use commas for natural brief pauses and dashes for cutoffs, restarts, or interruptions.
So if we look at the original
That's
data,
1998 study.
yeah, the 1998 one, it just completely like shattered everything we thought we knew about it. I mean, about how the cells actually communicate.
Oh, absolutely. Because before that, everyone just assumed it was like a direct chemical transfer.
Wow. That is wild. Natural notes. When we picture the human circulatory system, it's so easy to imagine this perfect closed-loop plumbing network.
Oh, absolutely. Like if you've got the heart pumping, the pipes are clear.
Right, and the blood just endlessly flows,
Mhm.
delivering oxygen, picking up waste, keeping the whole incredible machine running. It feels strictly mechanical.
It really does, until something goes wrong.
Exactly, because what happens when, say, a runaway truck somehow gets inside that pristine plumbing network? So today we are tearing open the textbooks on pathophysiology for a custom deep dive designed entirely for you. Our mission is to look at a 150-year-old medical mystery, figure out exactly how deadly clots form and travel, and explore why everything science thought it knew about this process was recently flipped completely upside down.
Yeah. It is going to be a wild ride.
It's a phenomenal topic, really, because on the surface, thrombus and embolus formation, I mean, it sounds like dry medical jargon.
Totally.
But you dive into the source material and you realize it is essentially a true crime story happening right inside the human body. It's full of forensic clues, mistaken identities, and this biological balancing act that is constantly teetering on the edge of a major crisis.
Okay, let's unpack this. Because before we can get into the mysteries of how these clots can actually kill a person, we first have to establish what they even are.
Right, the basics.
Yeah. Let's start with the medical definition of a thrombus. According to our source, a thrombus isn't just like thick blood. It is a solid mass that forms from the specific cellular components of your blood. So we're talking platelets, fibrin, red cells, and trapped white cells.
Yeah, those are the physical building blocks, absolutely. I mean, platelets are those tiny cell fragments that act like, well, like first responders to a site of injury.
Oh, right.
And fibrin is this tough, stringy protein that weaves them all together into a net. But if you look closely at the text, the real defining feature of a thrombus isn't just what it's made of, it's where and how it forms.
Right. There was that one really specific clause.
Exactly. A true thrombus must form inside a living blood vessel or inside the heart while the circulation is still intact.
Yeah, I noticed that clause. While the circulation is intact, it sounds like one of those minor technicalities a lawyer would put in a contract. Why does it matter so much that the blood is actively flowing?
Because that flowing environment fundamentally changes the nature of the structure. I mean, think about it. If your blood isn't flowing, say it's just sitting in a test tube and it turns solid, you aren't looking at a biological response to an injury.
You're just looking at old blood.
Right. You're just watching a stagnant liquid do what stagnant liquids naturally do. They coagulate and dry up. A true thrombus is an active, dynamic construction project.
Oh, I see.
It is actively fighting against a rushing current to build a wall. That hostile living environment is what makes it a pathological thrombus, rather than just, a puddle of dried blood.
Which makes total sense when you think about real-world scenarios. Like, we always hear about the risk of getting deep vein thrombosis, a DVT if you sit still for too long on, like, a 14-hour international flight.
Oh, yeah. That's a perfect real-world application.
Because your blood flow slows down in your legs, right, since you aren't moving your muscles.
Yeah.
And that sluggish current allows the construction project to just start building a wall where it shouldn't.
Exactly. The sluggish flow tips that delicate balance, and the platelets start laying down their net inside an otherwise completely healthy vein.
Wow. Which brings us to the second definition we need to tackle, which is the one that makes that long flight genuinely terrifying.
The embolus.
The embolus. If the thrombus is the mass forming on the wall of the vein in your leg, the embolus is the rogue traveler. Our source defines it as any material that breaks loose from where it originally formed, travels through the bloodstream, and eventually lodges somewhere it absolutely does not
It
belong.
completely obstructs the flow of blood.
Right. So to put this in everyday terms for you listening, a thrombus is like a localized traffic jam on the highway. There's a pileup in the right lane, the cars are getting tangled together, and it's slowing everything down right there at the site of the
You
crash.
have a localized problem.
Exactly. But an embolus is like a runaway truck that breaks off from that initial traffic jam, speeds down the open highway, and doesn't stop until it crashes into and completely blocks a tiny one-lane bridge miles away.
What's fascinating here is that the runaway truck analogy is great, but the source actually points out something that makes this even more complex. Yeah, the trucks aren't just made of old traffic jams. While most emboli are pieces of a blood clot that have detached that we call those thromboemboli, the category of what counts as an embolus is bizarrely broad.
Yeah, this part of the text genuinely shocked me. I always just thought an embolism was a blood clot on the move. That was it.
Not at all. According to the source, an embolus can be made of fat, can be a bubble of air.
A bubble of air?
Yep, it can be amniotic fluid, fragments of a tumor, or even something called bacterial vegetations. Literally anything macroscopic that gets into the bloodstream, travels, and blocks a vessel is technically an embolus.
I just need to pause and let that sink in for a second because the idea of a bubble of air acting like a runaway truck in our veins is wild.
It really is.
You think of air as harmless, but if a significant bubble gets into that closed plumbing system, it hits a vessel that is too small for it to pass through and acts like a physical wedge. Or tumor fragments, literal pieces of cancer breaking off and clogging a pipe.
It really highlights the extreme vulnerability of the circulatory system. I mean, it is designed to transport microscopic cells and dissolve nutrients. When you introduce macroscopic debris, the system simply cannot accommodate it.
It just fails.
Exactly.
Yeah.
Take the fat embolus, for example. If you were in a severe car crash and you break a large bone like your femur, the yellow fat marrow inside that bone can physically rupture into the torn blood vessels.
Oh, wow.
Suddenly, you have a glob of literal fat traveling up to your lungs.
Quite, that's horrifying. But I have to ask about one of those other terms you dropped because it paints an even worse picture. Bacterial vegetations. What on earth does that mean? Are we talking about plants growing inside the heart?
I know the word vegetation sounds like a garden, but in pathology, it refers to clumps of bacteria and cellular debris that grow on infected heart valves.
Yikes.
Yeah, they look like weird cauliflower-like weeds. If someone has a severe bacterial infection in their heart, these brittle weeds grow on the valve, snapping open and shut with every heartbeat.
And then they just break off.
Exactly.
Yeah.
Eventually, the force of the blood breaks a chunk of that weed off. Now you have a highly infectious solid mass shooting up into the brain, causing a stroke.
That is absolutely terrifying. But, figuring out what an embolus is made of doesn't solve the biggest problem doctors face.
Forensic proof, yeah.
Right. If a patient dies and you find a blockage during the autopsy, how do you actually prove that specific clot was the runaway truck that killed them? Because couldn't it just be like blood that naturally congealed after their heart stopped from something else entirely?
This raises an important question, and it is the ultimate forensic puzzle. And it brings us directly to a 150-year-old argument in pathology.
The autopsy room debate.
Exactly. The challenge is figuring out, is this a living clot or dead clot? Was this the murder weapon or just a red herring?
Let's look at the living clot first. The classical distinction, which our source says is still taught in medical schools today, relies on the fact that a true thrombus forms while the blood is still actively flowing. And because it fights against the current, it develops in these distinct, visible layers.
The flowing blood is the key variable here. Imagine you are standing in a rushing river, trying to build a dam. You throw down some sticks, but the water rushes over them. You throw down some mud, the water rushes over that.
You're fighting the current.
Right. A thrombus forms in exactly the same way. Platelets and fibrin deposit first against the vessel wall. Then the flowing blood washes over it, and red blood cells get trapped in that sticky net.
And then another layer forms.
Yep. Another layer of platelets and fibrin forms on top of the red cells, over and over again.
So this layering process leaves a physical record, kind of like the rings of a tree telling you the history of its growth.
That is a fantastic way to look at it. Under a microscope, or even to the naked eye, this produces visible laminations. The source refers to them as the lines of Zahn.
The lines of Zahn.
Yeah, named after a Swiss pathologist, Friedrich Wilhelm Zahn, who first described them back in 1875.
I just love that detail. A guy staring through a primitive brass microscope in the 1870s figures out how to read the history of a blood clot, and we still use his name for it today.
It's pretty amazing.
So the lines of Zahn prove the blood was actively pumping when the clot formed. But what about the dead clot, the post-mortem red herring?
Well, think about your river analogy again. If the heart stops pumping, the river stops rushing.
It just goes still.
Right, the blood just sits there and gels in place. Because there is no current to mix things up and smash the cells against the vessel wall, it doesn't form those beautiful alternating layers. Gravity simply takes over.
And this is where the source gets wonderfully, vividly morbid.
Oh, it really does.
As this post-mortem blood sits stagnant in the veins, it separates out by weight. The heavy red blood cells sink to the bottom, forming this dark red, gelatinous lower layer, and the lighter plasma and white blood cells float to the top, forming a pale yellow upper layer.
And do you remember the medical terminology for these two layers?
I do, and I hate it. The bottom is called currant jelly, and the top is called chicken fat.
It is remarkably descriptive, isn't it?
Descriptive is one word for it. I mean, why do medical professionals always use food to describe gross anatomy? Currant jelly and chicken fat. It's deeply unsettling. I feel like I'm never going to look at a jar of jelly the same way again.
It's a totally fair reaction.
Yeah.
But you have to put yourself in the shoes of a medical student.
Okay, fine.
Pathology is incredibly visual, and the human body can present just a confusing mess of colors and textures. When you are staring at a strange mass of tissue, associating it with something ordinary you've seen in your kitchen.
Like the yellow, greasy look of chicken fat.
Exactly. It makes it instantly identifiable. It burns the image into your memory so you don't make a mistake when a life or a legal verdict is on the line.
Okay, that makes sense. It's a mnemonic device, just a really, really gross one.
Extremely gross.
So if we go back to our autopsy scenario, the pathologist opens a blood vessel and finds a massive clot. If they see the alternating lines of Zahn, they know they're looking at a living thrombus.
Right, because it was actively fighting the current.
Exactly. It's highly likely this is the clot that stopped the blood flow to the heart or brain and caused the death.
But if they open the vessel and out slides this gelatinous, unattached blob that looks like currant jelly on the bottom and chicken fat on the top.
They know it's a dead clot.
Exactly. It formed after the patient died of something else entirely. They need to keep looking for the real cause of death. And 150 years later, that morphologic distinction is still one of the most reliable forensic tools we have.
Wow. So we've spent a lot of time in the 19th century here looking at morphology, like how a clot appears to the naked eye, but knowing what it looks like is very different from understanding how it actually works.
A completely different ballgame.
And as medicine advanced, scientists realized they had a massive blind spot. The map they were using just didn't match the territory.
This is the massive paradigm shift your source spends so much time on. Moving from the visual anatomy of a clot to the microscopic molecular mechanism of how it is actually built.
Right, so for decades in the 20th century, if you opened any medical textbook, thrombosis was explained by something called the coagulation cascade.
The old reliable cascade.
Yeah. It was always diagrammed as this complex, free-floating waterfall of chemical reactions. You know, factor A activates factor B, which activates factor C, and it was all supposedly happening just floating freely in the liquid plasma of your blood.
Which made logical sense at the time. I mean, blood is liquid, so it stood to reason that the chemical reactions causing it to solidify were happening freely within that liquid. It was taught as a linear series of dominoes falling over.
It sounds incredibly logical, so why on earth did we abandon it?
Because of a glaring clinical anomaly. The domino theory didn't actually match what doctors were seeing in real human patients.
What do you mean?
Let's say you have a line of dominoes. If you remove a domino from the middle of the line, the cascade should stop. All right.
Right, the chain reaction breaks.
So according to the 20th century waterfall model, if a patient was missing one of these blood factors, say factor 12, their blood shouldn't be able to clot. The domino's missing.
Makes sense.
But doctors found patients missing factor 12, and their blood clotted perfectly fine.
Wait, really?
Perfectly fine. Meanwhile, patients missing factor 8 couldn't clot at all. They had severe hemophilia. The waterfall model just couldn't explain this. If it was a single linear chain floating in the liquid, any missing domino should cause the exact same bleeding problem.
Oh, I
The fact
say.
that it didn't prove the domino theory was fundamentally flawed.
That is wild. So the whole medical establishment was memorizing a textbook diagram that was physically impossible in the real world.
Pretty much.
Which brings us to the massive disruption in 2001. Two hematologists, Maureen Hoffman and Dougald Monroe, looked at this broken waterfall and proposed an entirely new framework, the cell-based model of coagulation.
Yeah, Hoffman and Monroe realized that clotting isn't a free-floating plasma waterfall at all. They proved that it doesn't just happen randomly in the liquid. Instead, they argued that coagulation unfolds in distinct, overlapping phases directly on the surfaces of specific cells.
Here's where it gets really interesting. The source lists the phases: initiation, amplification, and propagation. But it doesn't really explain what those mean in plain English. How does a clot actually form on a cell surface?
Let's break it down. In the cell-based model, the cell surface isn't just a passive floor where things happen. It is an active participant.
Okay.
First is initiation. When a blood vessel is damaged, the cells underneath the lining are exposed to the blood. These specific cells have unique proteins on their surface. When the blood touches these surface proteins, it sends up a flare, initiating the process.
I got it.
Next is amplification. The signal from that flare recruits platelets to the exact site of the injury. The platelets stick to the cell surface and get activated, essentially preparing the ground.
Preparing the ground for the final step.
Exactly. Finally, propagation. This is where the heavy lifting happens. A massive burst of the protein fibrin is generated directly on the surface of those activated platelets, weaving the net that forms the solid clot.
Okay, so going back to our earlier analogies. The old 20th century model was like a simple line of dominoes falling over in an empty room. One blindly hits the next and it just travels across the liquid.
Right.
But this 2001 model, it's more like a highly coordinated construction site. You don't just have workers blindly throwing bricks into a river hoping they stick together. You have specific phases of construction happening directly on a scaffolding.
The scaffolding is the perfect word. The cell surface provides the scaffolding. And the source mentioned something really important here: cofactors.
Cofactors.
Yeah, cofactors are essentially the specialized tools that the biological construction workers need to build the clot. In the cell-based model, those crucial tools are only found attached to the scaffolding, the cell surface.
Oh, so if a reaction floats away from the scaffolding into the liquid plasma, it loses its tools and the reaction just fizzles out.
Precisely. And think about why that is biologically vital for your survival. If the waterfall of clotting enzymes were just freely floating and amplifying in the liquid plasma, what would stop your entire bloodstream from turning into a solid block of currant jelly the moment you got a paper cut?
Oh, wow. Yeah, if it's just a free-floating chain reaction, the whole river freezes up.
Right.
The scaffolding model explains how the body keeps the clot strictly contained to the exact site of the injury.
Yes.
It localizes the reaction. It keeps the process safe and controlled.
Exactly.
So we've gone really deep into the weeds of hematology here. Why does this matter for you, the listener? Why should you care that some textbooks had to be rewritten in 2001 from a waterfall to a cell surface? Well, both the text and our discussion point to a very practical, life-saving application. It completely revolutionized drug design.
It absolutely changed everything for pharmacology. Because before 2001, the older anticoagulants, the traditional blood centers,
Yeah.
they were essentially blunt instruments.
How so?
Well, because doctors thought clotting was a broad liquid cascade, the drugs were designed to just indiscriminately shut down the whole river.
Right. If you think it's a liquid domino effect, you just throw a blanket over all the dominoes. But what happens to the patient when you do that?
The patient suffers from what we call systemic bleeding. Because the drug is suppressing the entire liquid cascade everywhere in the body, the patient's blood can't clot at all.
So they fix one problem but cause another.
Right. They might stop the dangerous DVT in their leg, but they start spontaneously bleeding from their gums, their nose, or dangerously inside their brain or digestive tract. They lose the ability to heal even microscopic, normal wear and tear scrapes.
It's like trying to stop a bad construction project by carpet bombing the entire city. Sure, you stopped the rogue builders, but now nobody can repair a pothole anywhere.
That's exactly it. But once Hoffman and Monroe proved the cell-based model that thrombosis is governed by these specific overlapping phases on a cell surface, drug designers could change their entire approach.
They could get more specific.
Exactly. Newer anticoagulants are designed to act like molecular snipers. Instead of carpet bombing the river, these drugs target a very specific chemical reaction that only happens during the propagation phase, right on the cell surface scaffolding.
So they just take out the rogue workers on the scaffolding while letting the rest of the river flow normally.
Yes, they can prevent a pathological, life-threatening thrombus from propagating without completely destroying the rest of the body's ability to initiate a normal clot when you get a paper cut.
That is incredible.
Understanding the exact mechanism on the cell surface allows for drugs that are vastly more precise and infinitely safer for the patient.
We go from a blunt instrument causing systemic bleeding to a molecular sniper. All because two scientists decided to question a textbook diagram of a waterfall that didn't actually make sense.
That's a huge leap forward.
Let's quickly recap the incredible journey we've been on today. We started by defining the strict rules of a thrombus, a living, active construction project fighting the current versus the embolus, the rogue traveler that can be anything from a broken clot to bone fat or a bubble of air.
Right.
We ventured into the autopsy room to learn how to spot a post-mortem red herring, contrasting the gelatinous chicken fat of a dead clot with the living history recorded in the lines of Zahn. And finally, we witnessed a scientific revolution, moving from the physically impossible coagulation waterfall to the highly orchestrated, life-saving cell-based model of 2001.
If we connect this to the bigger picture, the story of thrombus and embolus formation is a perfect reminder that the scientific method is never truly finished.
Yeah.
What was undisputed, textbook dogma in the 20th century, was completely rewritten in 2001, and that rewrite is literally saving lives today. It reminds us that our understanding of the human body is always evolving. There is always a deeper layer of complexity waiting to be discovered if we are willing to question our assumptions.
Which leaves me with a final thought for you to mull over as we wrap up this deep dive. If our understanding of something as fundamental, as universally human, as blood clotting shifted from a free-floating liquid reaction to a highly specific event happening directly on the microscopic scaffolding of a cell surface, it makes you wonder. How much of human health and disease isn't just about the fluids pumping through us, but about the incredibly delicate microscopic surfaces that crash against every single second? Until next time, keep questioning the world around you.